Hello everyone, I'm Dr. Anderson from Natural Health Solutions. Today we're going to take a focused, evidence-based tour of insulin resistance. Not just what it is, but precisely why cells stop listening to insulin, and how we can restore that signaling. By the end of this talk you'll understand the molecular roadblocks, the measurable tests clinicians use, and the interventions, lifestyle, surgical, and pharmacologic that actually reawaken cells to accept insulin again. Let's begin. Insulin resistance is central to type 2 diabetes, fatty liver, and many features of metabolic syndrome. When cells don't respond to insulin, blood glucose rises, the pancreas overworks, and energy traffic inside tissues is disrupted. Clinically, insulin resistance predicts diabetes, cardiovascular disease, and functional decline. So reversing it is not cosmetic. It's foundational to restoring metabolic health. So here's a quick molecular primer. Insulin binds its receptor on muscle, fat, and liver cells, activating a cascade insulin receptor substrates, IRS, phosphoinositide 3, kinase PI3K, and AKT. A key downstream event is GLUT4-containing vesicles moving to the cell membrane so glucose can enter. In insulin resistance, the signaling cascade is blunted, IRS activity is reduced, AKT activation is lower, and GLUT4 fails to traffic effectively. Think of it as a communication breakdown. The insulin message never reaches the glucose gate. Now there are several proximate causes that interrupt signaling. First, toxic lipid species. Not total fat, but certain intramucocellular and intrahepatic lipid molecules, especially ceramides and some which directly inhibit AKT and other signaling proteins. Second, chronic inflammation. Low-grade inflammatory cytokines from enlarged adipose tissue recruit immune cells and serine phosphorylate IRS proteins, impairing signaling. Third, mitochondrial and endoplasmic reticulum stress. Impaired organelle function reduces metabolic flexibility, increasing reactive species that interfere with signaling. Fourth, altered gut signaling and metabolites. The microbiome, bile acids, and gut hormones modulate systemic insulin sensitivity. Critically, these problems are reversible. Let's walk through how interventions act at the cellular level. Exercise. Muscle contraction moves GLUT4 to the membrane through insulin-independent pathways, AMPK, and contraction-sensitive trafficking. Repeated sessions increase GLUT for expression and mitochondrial capacity, improving insulin responsiveness for hours to days after activity. Weight loss and reduction of ectopic fat. Losing visceral and liver fat reduces the pool of toxic lipids and inflammatory signaling molecules. The result, restored insulin signaling in liver and muscle. Medications. Different drugs act through different mechanisms. Metformin improves hepatic insulin sensitivity partly via AMPK and mitochondrial effects. Thiazolidine-adiones remodel adipose tissue to improve lipid buffering. And GLP-1, GIP receptor agonists produce large weight loss, and favorable adipose and hepatic effects that translate into improved peripheral insulin sensitivity. Bariatric surgery in many patients. Insulin sensitivity improves within days, often before large weight loss, due to dramatic changes in gut hormone release, bile acids, and nutrient flow. Researchers are now targeting the toxic lipids directly. For example, blocking ceramide synthesis or enhancing ceramide clearance, and exploring how modulating the microbiome or bile acid signaling can shift whole-body metabolism. These are promising but largely experimental in humans today. Another growing area is improving mitochondrial quality and reducing cellular stress to allow insulin signaling to function normally. To judge progress, we use a combination of tests. HbA1c and fasting glucose. Long-term and immediate glycemic control. Oral glucose tolerance test, OGTT. Dynamic measure of glucose handling. Insulin and OMA are estimates of insulin resistance. Imaging for liver fat ultrasound, MRI, or biomarkers for non-alcoholic fatty liver disease when indicated. These tests allow clinicians to track biological change, not just weight or appearance. Let's put it all together in a practical, evidence-based plan that a clinician and patient could follow. Here's a stepwise approach to managing insulin resistance. Begin with assessment, fasting labs, HbA1c, lipid profile, basic liver tests, and, if indicated, an OGTT or imaging. Lifestyle core. Aim for regular aerobic activity. Is greater than or equal to 150 minutes per week, plus 2 to 3 resistance sessions weekly. Start with manageable steps and build progressively. Exercise both acutely mobilizes GLUT4 and chronically increases its abundance. Targeted nutrition, a modest, sustainable calorie deficit to lose visceral fat. Emphasize whole foods, increased fiber, lean protein, and reduced refined carbohydrates and saturated fats, which can promote harmful lipid species. Time-restricted eating may be helpful for some people. Medication where appropriate. Discuss metformin for high-risk individuals. Consider GLP-1, GIP receptor agonists in those with obesity and metabolic disease under medical supervision. Thiazolidinediones may be useful for select patients, but have specific side effect profiles. Advanced options, bariatric surgery for eligible patients. Investigational therapies within clinical trials for ceramide targeting or microbiome modulation. Always individualized choices based on risk, comorbidities, and patient preference. Let me leave you with 3 takeaways. 1. Insulin resistance is a reversible, biologically understandable state, not a moral failing. 2. Exercise and reducing ectopic fat are the foundational, mechanistic ways to restore insulin signaling. And 3. Modern pharmacology and surgery are powerful adjuncts for those who need them, but must be used thoughtfully. No single magic bullet. The most durable changes combine behavior, sometimes medication, and ongoing monitoring. Important caveats. Improvements can be rapid in some pathways. For example, hepatic insulin sensitivity often improves quickly with reduced caloric intake, while skeletal muscle insulin sensitivity may take weeks to months of consistent training. Medications have side effects and need clinician oversight. As always, thank you for watching and make sure you catch next week's deep dive. You can also subscribe to my channel where we explore topics in depth every week. As always, safety first. Consult your clinician. See you next time.